Good afternoon, everyone. I'm sorry. I always have a problem because when there is a huge podium, I'm never seen. So, but anyways, big shout of thanks to Pragnesh and the organizing team of FPNATCON. What I'm going to talk today is it's beyond inflammation and infection, cough. So, as a general practitioner or a private practitioner, how are you going to approach a patient who comes to you for the cough? So we all know what is cough. Cough is basically, a reflex mechanism, right? What it helps is to prevent aspiration. In Gujarati, what we say that antras jai, right? So that's preventing aspiration and also taking care of any clearance of the airway secretions or maybe some sort of a foreign sensation. Pathologically, excessive and protracted cough is common and it's a very disabling complaint. Most of you would probably get a patient to you 50 to 60% of the times in your OPD for a cough, right? Severe cough causes major decrement in the quality of life because it hampers quality of life. It causes cough syncope. You probably might be coming, itlu બધું ખાંસી ખાધું અને ચક્કર આયા ને પડી ગયા. So that is cough syncope. Dysphonia, social isolation, they cannot take part in a lot of social activities, depression, long-standing cough, and we have been observing this post-viral, post-COVID, post-H1N1 patients having cough for a long time. And cough is one of the most common factor for a long COVID, right? So we had a lot of patients who came with cough for a long time after COVID. And they have social isolation, they are in depression, so on and so forth. So this is the slide which is probably the crux of me and the whole talk. If you look at it, more than 50% of the times, patient going to a general practitioner is because of respiratory symptoms. Either there is cold, there is cough, breathlessness, wheeze, or a fever. So fever with cough, this is the most common symptoms that a patient would come to you, right? Out of which, if you look at it, the cough is a predominant symptoms in 59 to 60% of the times. So what is the pathophysiology of the cough? What causes cough? Right? Cough is basically a reflex mechanism whenever you have an irritation in anywhere in the respiratory symptoms. So my talk is for 20 minutes, which has been given to me. But if Pragnesh allows, I would probably, in fact, also teach you where the irritant is when the patient comes to you just by the quality of the cough. So after my talk, if I get 5 minutes extra, I would probably tell you how the quality of the cough is and where exactly you can diagnose where the irritant would be, and that is how you can chase the patients. So what normally we have is, we have a deep inhalation whenever there is an irritant anywhere in the respiratory system, where there is a cough receptor which gets stimulated, and then there is a stimulation of the vagus nerve, which would go to the cough center in the brain, and then there is a deep inspiration, and then a compression, and then what happens, that will, the vagus nerve and the spinal nerve through an efferent pathway stimulate the respiratory system and the patient would cough. So it's something like this. If I have irritant anywhere in my body, right from the pharynx up to the alveoli, what the first thing would be, I would inhale first, like this, right? Because there is an irritation. The moment I inhale, and then there is a compression from outside because of the positive intrathoracic pressure. And then I will just cough out. So this is how there is a signal which goes to the pons and medulla, and then through the vagus, it would come back to the respiratory system, and then you will have a forceful expiration. So what are the types of cough? So we have a productive cough and a dry cough. So whenever you have cough followed by a phlegm or a sputum, it's a productive cough. And when you have only cough which is making noise or just not bringing out anything, no wheeze, nothing, then it is a dry cough. And then you have 3 types of cough depending on the duration. So you have an acute cough, then you have a subacute cough, and you have a chronic cough. So acute cough is cough which lasts for anywhere around 6 to 8 weeks. 3 weeks. Subacute cough is 3 to 8 weeks, and any cough which lasts for more than 8 weeks is a chronic cough. So what are the causes of acute cough? They are upper respiratory tract infections, laryngitis, pharyngitis, bacterial, viral, fungal, tuberculosis, so on and so forth, pneumonia, asthma, congestive cardiac failure, pulmonary embolism, foreign body aspiration. And what are the red flag signs? So when would you refer, when a patient comes to you, when would you refer that patient to a physician or a pulmonologist like us? In case of an acute cough, if the patient comes to you and says that he has a cough with blood in the sputum, which is hemoptysis. If the patient says that I become very breathless, I'm wheezing terribly, right? If you look, the saturation is falling down. If the patient has got hoarseness of voice, which is lasting for a long time along with cough, if the patient is a smoker, or if a patient has a cough syncope. So these are the red flag signs where you need to act fast. Let's now talk about chronic cough. So what are the causes of chronic cough? And this is how you are going to approach as a general physician. So causes of chronic cough are basically cough variant asthma, it is psychogenic cough, it is neurogenic cough, congestive cardiac failure, gastroesophageal reflux disease is very common these days. So any patient who says that I have a heartburn and he is coughing, which is a dry cough, probably you need to rule out gastroesophageal reflux, because we get a lot of patients who have been treated as asthma with a lot of inhalation therapy, and basically if you take a proper history, it is just a reflux disease, and we send it to a gastroenterologist. Just one pill is going to take care of all those symptoms. So those things are very common. Chronic lung infections like tuberculosis, pneumonia, so on and so forth can be probably a cause of a chronic cough. And the other thing would be cardiac origin, which I said. So now, whenever a patient comes to you in your OPD, the first thing he says that I've been coughing for a long time. The first thing you need to find out the history. The history is very pertinent. You have to be very meticulous when you take them. Are you taking any medications? If they say yes, then for blood pressure, what medications you are taking? Can anyone from the crowd tell me any blood pressure medication which can... Perfect. So that's what. If a patient is on any ACE inhibitor or a patient is on a beta blocker and the cough is not coming down, that's the only thing you need to do. Right? You just don't have to go on getting a battery of investigations for that patient. That these are the things that I'll get it done, and you give them a lot of medications. So that is very important. As Madam rightly said, it's the ACE inhibitor which probably causes the cough. And this is the pathophysiology, how the ACE inhibitors would cause. It causes the stimulation of some of the receptors, and that causes a efferent vagal stimulation and cough. So now I have made some of the cases to make it more interesting, so that how do we approach to the cough is going to probably be understood well. So this is a 40-year-old female. She's a known case of bronchial asthma. She presents with fever off and on, excruciating cough with mucopurulent phlegm. So this is a productive cough. She has a weight loss. She was treated with anti-tuberculosis medications for 6 months, were treated with various antibiotics, course of steroids, and in spite of that, there was a partial improvement. Hemoglobin was 12.8, total count was 10,000. IgE was 5,767, absolute eosinophil count was 814. So this is going in favor of allergic cough, where the IgE is high, eosinophils are high. So this patient has got a post-infective allergy, which is called atopicity, is going in favor of the same. But why does she have a mucopurulent cough? That should come to your mind. If she has an allergic cough, why is she bringing out so much of sputum? Why the flame is coming out, right? We did her pulmonary function test. She had severe obstruction. And when you look at the CT scan, I'm sure if you look at this, she had some amount of bronchiectasis, right? So the reason for her having lot of mucopurulent phlegm, she had cough with bronchiectasis, which was getting infected again and again. So this is a pulmonary cause of a chronic cough, right? So as I said, when you approach a chronic cough, you have pulmonary cause, you have cardiac causes, you have drug-induced causes, you have neurogenic causes, you have psychological causes. When you have such a history, it is a pulmonary cause of a chronic cough. So asthma, COPD, upper airway cough syndromes are one of the reasons for chronic cough. The other one which is very common is bronchiectasis in our country. We see a lot of patients having a sinopulmonary diseases as well, right? That's a cause. Interstitial lung disease, pulmonary edema. So these are basically a pulmonary causes of chronic cough. Let's go to case 2. This is a 51-year-old male, tobacco chewer working in the city corporation, diagnosed as allergic rhinitis for 30 years. He is on Montelukast, intranasal corticosteroids. As and when required, antihistaminic, has a seasonal variation. Again, the eosinophil is 14%. Absolute eosinophil count is 850. Aspergillus specific Ig 0.1, Ig 140, and spirometry shows nearly a normal lung function. X-ray shows bilateral maxillary sinusitis, and HRCT thorax is normal. Can anyone tell me what might be the cause of the cough of this patient? Perfect. Perfect. So this patient has got an upper airway related cough where the sinus is causing a post-nasal drip. And this post-nasal drip is so high during the nights. So if the patient comes to you and he says that I cough the moment I lie down, you know, I have irritation in my throat, something is sticking and I need to clear that off. That's the reason, that's the post-nasal drip because of upper airways. Look at, if I don't treat this upper airways and post-nasal drip, this patient eventually would become asthmatic. Case 3 is a 55-year-old male is referred for evaluation because of persistent cough for 6 months. Cough is not associated with exertion or shortness of breath. Non-smoker, not on any drug, which can cause cough. No rhinitis, no sinusitis. Has occasional heartburn in past 3 years. Exactly. X-ray chest is normal lung functions, right? So can this be GERD? Yes, it can be. Right? So this patient who has got a cough for 6 months, right, only one history, whether you have a heartburn. Does the cough increases after meals? What is the time you take your meal? If you said I take meal at 10 o'clock and sleep at 11 o'clock, there's going to be a great huge reflux. A simple PPI is going to help. Right? In this patients, no need for inhalation therapy, no need for anti-allergics, no need for steroids, nothing. In fact, steroids and all those things are going to worsen the GERD. And when would you refer the patient to a gastroenterologist? After giving a PPI for at least 2 months, it does not improve, then only you can send the patient. And if you are suspecting a hiatus hernia, then of course, Pankaj Bhai is there. So, and if the patient needs to be operated for the same, you need to refer the patient. But before that, you need to give a trial of a PPI for at least 2 months.
2 minutes, madam.
Yeah, I'll be fast. So this is a 17-year-old female diagnosed as exercise-induced asthma, dyspnea, cough, which lasted several hours of exertion, had frequent panic attacks during the situation. She was given salbutamol, she was given, fluticasone, Montelukast, steroids, bronchodilators. We did her pulmonary function test, which was, okay, not bad. But if you look at this, she had got fixed airway obstruction in upper airways and lower airways. Can this be psychiatric disorder? Because she had panic disorders, right? Lung functions were normal. Patient was given lot of medications. Upon sending to a psychiatrist, we found out that she is having anxiety and panic disorders, and she had a vocal cord dysfunction. So only counseling and sending her to a speech therapist helped. So just looking at the pulmonary function test curve, right, you can decide that this patient has got a psychiatric or a psychogenic cough. So, what is a psychogenic cough? It's a cough without obvious medical etiology where everything has been ruled out and still the patient is coughing and all the reports are normal. And this cough is refractory to medical management and you are eliciting a history of psychiatry or psychological basis. This is a 46-year-old diabetic man admitted to the hospital with a dry cough and shortness of breath. He has undergone PTCA, had COVID during the first wave and was on NIV for 7 days. When he was admitted, he had, he had a blood pressure of 95/60, oxygen saturation of 89%, bibasal crackles, bilateral extensive edema, puffed up face. Echocardiography showed an ejection fraction of 30%. A patient had a paroxysmal nocturnal dyspnea. Can anyone tell me the reason for cough? The patient has congestive cardiac failure, right? So you just need to, refer it to a cardiologist or probably treat the congestive cardiac failure with a diuretics, non-invasive ventilator, and symptomatic treatment. So, the cough can be treated with antiarrhythmics if the patient has got arrhythmia. You can treat the patient with diuretics, and you can take care of those type of chronic coughs where the patient is telling that the moment I lie down, I'm coughing and the ejection fraction is low. And this is my last case. Is a 41-year-old male diagnosed as allergic rhinitis for last 5 years. I'm not sure whether really allergic rhinitis or not. Dry aching cough on Montelukast, intranasal corticosteroids. All investigations are normal. Had constant cough after talking, laughing, and strong smells. Can this be neurogenic? Was treated, all ruled out, right? Can you think that this patient can have a neurogenic cough? It's a dry cough, hacking cough, not treated with, not controlled with any of the medications. How do you evaluate such patients? So neurogenic cough is a type of a cough where it is related to overtly sensitive nerves in the upper airways, a voice box and the larynx. The nerves that control sensation in the throat becomes very sensitive to very sensory stimuli. So laughing causes cough, smells cause cough, right? A recent cold or upper respiratory illness would probably have that cough last for a long time. How do you treat these patients? After you rule out all the types of cough, if the cough is not going, you can give them a trial of amitriptyline. Giving them an amitriptyline, all methylcobalamin or a gabapentin is going to take care of a neurogenic cough. But before that, you need to rule out all the causes of the cough which I have elucidated before. So this is the Indian consensus on the algorithm of the approach of the cough. I'm not going to go into the depth of it because I've already said first rule out drugs, then a pulmonary cause, the upper airway cause, cardiac cause, GERD, and the moment you come to each and every one, you need to chase that and treat them. So the take-home message, ladies and gentlemen, is distinguish between acute, subacute, and a chronic cough. History is very, very pivotal. Physical examination are usually adequate for diagnostic workup of patients with cough. Chronic cough, patients need immediate further diagnostic measures. Therapeutic suppression of cough may be either disease-specific or symptom-related. First, consider causal treatment of the patient with cough if possible. If not, a proper approach to the cough is mandatory, and proper algorithmic approach will help in correct diagnosis and a therapeutic approach. Thank you very much, and I'll be happy to take the questions. And if I have 2 minutes, I